Thank you for being here today. This is Yuvraj, your host for this webinar. I request the Dr. Sangini to start the session. Thank you and over to you, ma'am.
Good morning. Today I'll be talking about speech and swallowing therapy after head and neck surgeries. So I would like to describe the topic under the following headings. I'll be describing the problem statement, briefly describing the normal swallow anatomy and physiology, dysphagia post-surgery and what are the key considerations post-surgery, radiation associated dysphagia, and management and rehabilitation of voice, speech and swallow. So coming to the problem statement, head and neck cancers, they contribute to a major chunk of cancers in general, and the modality of treatment is not only surgery but also radiation has an important role. So considering the anatomical location of these cancers usually involve the tongue, the oral cavity, the pharynx, the larynx. So these are all structures which are very important for speech and swallowing and voice function. So any surgical intervention in this area has a debilitating effect on both speech, swallowing, as well as causes a lot of dysphagia. And it's not only surgery, it's also radiation. So as we all know that early cancers can be treated usually with single modality, that's surgery or radiation, and advanced stage cancers usually require a bimodality treatment. Also, surgery may not be the end of the treatment. Few patients also, based on the histopathology report, may also go in for adjuvant radiation or chemo radiation. So how does all of this impact dysphagia? Or how does this impact speech and swallowing? So like I've already mentioned, excision of structures which are important for protection of airway, bolus formation and transfer lead to post-surgical dysphagia. There is impairment of speech, there is change in voice, and often the treatment compounds the damage caused by the cancer. So even if we just let the cancer be, the cancer itself will produce signs and symptoms which will lead to impairment, and the treatment may just compound these effects or functional deficits. So what are the considerations when it comes to head and neck cancers? What determines the severity of impairment? It depends on the site involved, the stage of the disease, the extent of surgical resection, the type of reconstruction, and the modality of treatment, whether it was only surgery, whether it was surgery followed by chemoradiation or only chemoradiation, as I shall describe in my further slides. Why are we discussing this topic? Why is this so important? This is important because it has a great bearing on the patient's life in terms of dysphagia, which causes weight loss, malnutrition, dehydration, poor immunity, makes the patient susceptible to infections. Because of aspiration, there is aspiration pneumonia and lower LRTIs, which take long time to cure and basically compromise recovery for the patient. There is prolonged dependence on non-oral feeding modalities like RT or even PEG may be required in few cases. There is definitely reduced treatment compliance for someone undergoing radiation who develops oral ulcers and sores. May hamper the treatment and may also lead to temporary cessation of the treatment, only to be resumed after the side effects are healed. Then prolonged recovery, delayed wound healing. It majorly impacts the quality of life and survivorship. It impacts communication and social well-being. Not being able to communicate often leads to social isolation for these patients. So starting with the topic proper, coming to the normal swallow, I'll briefly be describing the anatomy and physiology of what we constitute a normal swallow and how this gets affected in head and neck, post head and neck surgeries. So, just a summary of all the structures, their muscles, and the role that they play in swallowing. So, lips, they maintain a seal and avoid spillage of bolus. The jaws, they're extremely important for because the muscles of mastication and suprahyoid infrahyoid muscles, they move the mandible. Very important in mastication and bolus preparation, also important for speech. The buccal mucosa, or the buccinator complex, it provides force, aids in bolus formation, and it pushes the bolus medially in between the teeth and tongue, and it ensures that the bolus remains in between the occlusal surfaces of the teeth. It aids in bolus return from the vestibule into oral cavity and prevents premature movement of bolus into the oropharynx. The tongue, very, very important for speech, taste, and deglutition. So, range of motion of the tongue is very important for bolus formation. Coming to the soft palate, it provides a separation it secures the nasopharynx from soiling, and it prevents nasal regurgitation. The pharynx, shortening and widening of the pharynx during swallow is important. And this is brought about by the muscles, the external circular muscles and the internal longitudinal muscles. The larynx, it protects against aspiration, control of the laryngeal inlet by the extrinsic and intrinsic muscles, and hyolaryngeal elevation. They are important steps in swallowing. Cricopharyngeal sphincter. Now, this is a point where the laryngopharynx joins the esophagus. It has sphincteric action, and post passing the cricopharyngeal sphincter, the bolus enters the esophagus, which is a muscular conduit which connects the pharynx to the stomach. And once the bolus finally reaches the stomach and leaves the esophagus, that determines the end of the swallowing function. Now, coming to salivary glands, they are they have a huge role in deglutition, because saliva is very important for maintenance of oral hygiene, lubrication of the oral cavity. Also, it has many digestive enzymes which are useful for breaking down food, converting it into a bolus. It is useful for speech production. A dry mouth usually impairs good speech. So, average volume of saliva which is secreted in 24-hour period is around 1 to 1.5 liters, and this takes a major hit post radiation. So, that I shall be describing. Now, coming to the normal swallow, what constitutes a normal swallow? The swallowing mechanism is partly reflex and partly under voluntary control. That is partly voluntary and partly involuntary. So, it can be divided into three broad phases. One is the oral phase, second is the pharyngeal phase, and third is the esophageal phase. The oral phase is further divided into preparatory and transit phases. This is a voluntary phase. It is slightly different for solids and for liquids. It is basically a mechanical stage where the food is prepared for swallowing. So first there is mastication and pulverization of the food to bring it to a suitable consistency. So this is what is known as processing of the food, and solids require more processing as compared to liquids. Liquids are usually contained in a furrow made by the tongue, and they're usually stored there with minimal mixing and they're usually diluted with saliva before swallowing. Now, this stage lasts for around 1 to 10 seconds, and airway remains open during this stage. A breakdown of the stage, what exactly happens? There is lip closure to hold the food in the mouth. There is rotatory motion of the jaws for chewing. Lateral rolling motion of the tongue occurs to place the bolus on the teeth before mastication. Tongue has a very important role in the oral phase. It is important for bolus formation. And at the end of the oral preparatory phase, the tongue pulls the food together into a bolus, holds it cohesively on the floor of the mouth against the hard palate in preparation for the beginning of the oral transit phase. Now, the oral transit phase is the movement of the bolus from the front of the oral cavity to the pharynx, where the pharyngeal phase of swallowing is initiated. Tongue movements are again critical because they cause backward propulsion of the bolus till it reaches the pharynx. A prerequisite is mandibular elevation. Stabilization and elevation of the mandible, it is necessary for adequate lingual pressure generation. Now, tension in the buccal musculature contributes to this propelling action of the bolus backwards. And as the bolus reaches the back of the tongue, the soft palate is elevated by the levator villi palatini and the tensor villi palatini to protect the nasopharynx from regurgitation, soiling of the nasopharynx. Posterior tongue is simultaneously elevated, thus preventing uncontrolled spillage of the bolus into the pharynx. Now, coming to the pharyngeal phase, it is an involuntary phase. So, till the oral phase, swallowing can be controlled. We can stimulate the anterior part of the oral cavity and initiate swallowing. But once the bolus reaches the anterior and posterior pillars, it becomes involuntary and the pharyngeal phase is initiated. It begins at the point of the bolus leaving the cavity and entering the pharynx till it reaches the esophagus. Now, this phase is physiologically more important as a very important event occurs, which is airway protection. So the bolus must enter the correct conduit and should not enter the airway, and this is what is ensured during this phase. It is a 1 to 2 seconds duration, and a very fine coordination is required between swallowing and ventilation, which is essential for airway protection. So what exactly happens as the bolus enters the oropharynx and it touches the key trigger points, which are innervated by the glossopharyngeal nerve, which is basically the anterior and posterior pillars. A response is initiated and the constrictors, they relax and the pharynx gets dilated. Once the bolus passes the palatoglossal and the pharyngeal arches, swallowing is involuntary. A breakdown of the phase. 4 events usually occur. One is velopharyngeal closure to prevent backflow or nasal regurgitation, tongue-based retraction to propel bolus through the pharynx, pharyngeal contraction to clear the residue through the pharynx, second, hyolaryngeal elevation to close the larynx to protect the airway, laryngeal closure and opening of the cricopharyngeal sphincter to allow bolus to pass into the esophagus. So, describing the airway protection a little bit, what exactly happens? There is cessation of airway momentarily, that is less than 1 second during this phase, and this is known as swallow apnea. It is of utmost importance to protect lower airways, and if this is not happening, then this is where aspiration can occur. So, there is contraction of the diaphragm. So contraction of diaphragm is inhibited, which prevents simultaneous swallowing and breathing, soft palate elevation to seal the nasopharynx and vocal cord closure. Coming to the final phase, which is the esophageal phase, it begins with the relaxation of the cricopharyngeal sphincter. The bolus enters the esophagus, true peristalsis takes over, which pushes the bolus into the stomach, and the normal esophageal transit time is around 8 to 20 seconds. Just describing the neural control a little bit. So the afferents for swallowing are picked up from the mucus. They are the sensory part of cranial nerve 5th, 9th and 10th. Which innervate the mucous membrane, anterior and posterior tonsillar pillar, soft palate and posterior pharyngeal wall. So these afferents are picked up, then they're sent to the swallowing center, which is in the floor of the 4th ventricle in the medulla, and this sends efferents to the motor parts of the same 5, 9, 10 and 12 nerves, and this causes movement of the respective muscles. So the medulla is not the only region which controls swallowing. The cerebrum has certain centers which also control swallowing. Medulla is of importance because since there is a fine tuning between respiration and swallowing, so that control is in the medulla, and which is why the respiratory center is in the medulla, and which is why this is of importance. Now, coming to impact of surgeries and what changes does surgery bring? So, oral surgery, lip, buccal mucosa, post-glossectomy, oropharynx, larynx, hypopharynx, maxilla, and skull base I'll be describing. So, key considerations for lip resection. What is it that we want to know, and what impacts functionality post lip resections is that whether the commissure is resected or not, the closure, whether it's primary closure or closure with a flap. So primary closure usually results in microstomia, and flap closure usually results in macrostomia. It has been seen that functionality in microstomia is better as compared to macrostomia because a lot of bolus leakage and drooling occurs. Also, loss of sensation is important. Now, coming to the loss of function, what does that lead to? It leads to anterior bolus escape and drooling. There is difficulty in intraoral and buccal pressure generation. There is a delay in bolus transport to the pharynx. There is poor bolus hold, and there is impaired sucking. Coming to the next part, which is buccal mucosa. Buccal mucosa impacts both speech and swallowing. So in speech, there is altered oral resonance, there is reduced speech intelligibility, and there is poor articulation. In terms of swallowing, there might be trismus, there is impaired chewing, reduced cheek support. There is reduced bolus hold and control. It is then bolus preparation is affected. There is reduced efficiency. Then intraoral pressure generation during bolus propulsion is very less, and reduced oral sensation. Coming to floor of mouth resections. Now, floor of mouth resections per se, they don't have a major impact on dysphagia, but since the muscles of the floor of mouth, they get disarticulated, and these usually may be combined with resection of the central arch of the mandible. So it can lead to a lot of aspiration as tongue hold and hyolaryngeal elevation is impacted. So this basically does not really impact swallowing, but can cause a lot of aspiration. Mandibular resections. Now, arch of the mandible I've just explained impacts more, has a major impact on aspiration. Now, that's because of the muscles of the floor of the mouth, they lose their attachment. Then mandibular discontinuity in case of segmental mandibulectomy. This is important because the act of mastication and the pressure required for mastication, that will not be possible. Now, this is very important for stabilization of swallowing. Also, malocclusion with the segmental mandibulectomies may occur. So, proper bite may not be possible, and it may not be possible for the patient to take solid food that easily. Then with segmental mandibulectomy, there's sectioning of the inferior alveolar nerve, which leads to anesthesia of the lower lip, chin, skin, ipsilateral mandibular teeth, and alveolar processes, which results in drooling. Marginal mandibulectomy affects mastication because again there is a loss of teeth and grinding action cannot take place. Coming to oropharyngeal surgery, tongue-based resections. Now, pharyngeal phase is affected and there is a very high risk of aspiration. So it has been seen that tongue-based resections of more than 25%, there is an inability to trigger a pharyngeal swallow and difficulty to clear the bolus from the pharynx. This leads to severe aspiration. There is poor or incomplete hyolaryngeal elevation, impaired epiglottic inversion, delayed swallow initiation, premature spillage of the bolus, poor pharyngeal contraction, reduction in sensation, which leads to again a delay in initiation. Then patients with tongue-based resection, they usually have a very peculiar complaint of sensation of food sticking in the throat or the chest. So this is because of loss of sensation. Then there is odynophagia, pain, and burning sensation that can occur, and this definitely impacts voice as well. Soft palate resections. Now, so post resection, there might be post operative scarring, which might impact mobility of the soft palate, leading to nasal regurgitation and hyper or hyponasal voice. Lateral or posterior pharyngeal wall resections, they usually lead to reduced contraction of the pharyngeal constrictor muscles, which leads to an impaired pharyngeal transport of bolus, which is marked by increased pharyngeal residue and leads to aspiration. Glossectomy. Now, there are multiple considerations when it comes to tongue resections or the anterior tongue resections, since it has a major role in preparatory phase. So, any resections which impact the where a major volume of the tongue is lost, that will impact the oral preparatory phase. So there is going to be lengthened oral preparatory time. There is loss of mobility of the tongue. There is loss of tongue palate contact. There is reduced oral transit. Then a large amount of oral residue remains. There is increased residue in the pharynx, and hyolaryngeal elevation is impacted, and there is stasis in the vallicula, which leads to premature spillage and aspiration. Again, key considerations: size of the lesion, whether the tip is involved or not. This is very important for speech and articulation. Then site of resection. Again, I've already explained that swallowing outcomes are worse for tongue-based resections versus anterior tongue resections. And type of reconstruction, whether we are closing with a primary closure or we are doing a flap closure. Now, size of the lesion, it has been seen that large tongue lesions, they are more prone to have aspiration because of premature spillage. So 1/3 to half tongue resection, swallowing is not that impacted. But again, if it involves the base tongue or concurrent floor of mouth, then again aspiration, there is a high chance of aspiration. For a total glossectomy, aspiration is as high as 10 to 37%, and usually a concurrent total laryngectomy is also advocated for such patients to protect against aspiration. Now coming to reconstruction, whether we are doing a primary or a free flap closure. So the dictum is that for small oral defects less than 20% tongue resections, we usually do a primary closure. It has its own advantages. There is better swallow, but again the amount of functional tongue is reduced, and also if tethering of the tongue of the remnant tongue occurs, then it reduces mobility and it reduces the tongue palate contact area and increases residual food particle deposits within the oral cavity. For large oral tongue defects, more than 40% tongue resections, we usually prefer a free flap. This has again advantages in the sense that it gives effective mastication. The disadvantages, it's an adynamic structure and does not have any sensation. For intermediate defects, there is no consensus as of now, and it may depend on the disease characteristics, on what kind of reconstruction we are choosing. Now coming to the resection of the maxilla, again it creates an oronasal or a oromaxillary fistula, which leads to regurgitation. There is loss of tooth-bearing segments. Repair is done either by flap or a prosthesis, which is mostly an obturator. And the aim of the reconstruction remains to reconstruct adequate tongue palate contact and so that the bolus can be propelled posteriorly. Skull-based surgery. So acute post-operative dysphagia after a skull-based surgery is usually due to direct injury to the cranial nerves. Then delayed dysphagia after skull base, it may depend on the approach that was used for accessing the skull base. Anterior approaches, which usually involve maxillectomies, they cause palatal defects and nasal reflux. Lateral approaches, which go through the zygoma or the mandible, they injure nerves. And temporal bone resections and lateral approaches, where the temporal bone is involved, they may injure the facial nerve. Also, direct injury to the pharynx may occur during skull base surgery, which itself can injure the musculature of the pharynx and cause dysphagia. Coming to total laryngectomy, so a total laryngectomy has major life-changing implications on the patient. There is a permanent neck stoma, there is change in breathing, there is change in swallowing and loss of normal voice production. So it has been seen that all laryngectomies, they have a modified swallow, which is not the same as a normal swallow. So what are the differences in a alaryngeal swallow versus a laryngeal swallow? So as we can see that the oral and the esophageal phase, they remain the same. It is the pharyngeal phase that is basically affected in cases of laryngectomy. So pharyngeal phase, in cases of laryngectomy, the soft palate elevates, the base of tongue approximates the posterior pharyngeal wall. There is partial or reduced stripping action of the posterior pharyngeal wall due to surgery and denervation. Bolus transits the pharynx under gravity and power created, and then the swallow sequence follows. So in post laryngectomy, it's basically all gravity directed swallow which happens rather than the muscle strength directed swallow which occurs usually. In case of the laryngeal phase, the suprahyoids which we have resected, they have to be reattached. They will contract, pull the reconstructed thyropharyngeus muscle, and this will further pull the reconstructed pharynx. And again, this the strength of the muscles is very less as compared to normal, and it's basically gravity directed. Now, coming to the surgical techniques, what are the intra-op considerations that we can consider once we are doing a total laryngectomy, so that we can have a better outcome in terms of voice and swallowing? So while resecting the tumor, we have to conserve as much pharyngeal mucosa as possible over the cricoid reach in the piriform fossa and vallecula. The thyropharyngeus and cricopharyngeus muscle, they should be dissected off the thyroid lamina on both sides and should be preserved as much as possible. Mucosa of the uninvolved piriform fossa should be preserved. And in case where we do not have enough or adequate residual mucosal strip, then we must do a flap augmentation. Then we must reconstruct with a flap to prevent pharyngeal stenosis and functional impairment. So coming to organ preservation surgery, so does organ preservation always translate into functional preservation also? In cases of supraglottic and vertical partial laryngectomies. So the answer is that in case of horizontal partial laryngectomies, since the structures resected, they are usually involved in protection of the airway. So there is a very high rate of aspiration, and 74% aspirations have been reported in horizontal partial laryngectomy, and these patients, they have a very high rate of, consequently they have a very high rate of aspiration pneumonia. This is not the case with vertical partial laryngectomies, because again it all depends on what structures we are resecting. So the arytenoids and the vocal processes, they usually and the hyoid, they usually spared. So the incidence of aspiration is very less compared to a horizontal partial laryngectomy, and also return to normal diet is faster with vertical partial laryngectomies. Now coming to tracheostomy, there is often this conception that a tracheostomy is protective for the lower airways against aspiration. This is not the case always. An inflated cuff is not protective against aspiration in tracheostomized patients. The cause of aspiration after tracheostomy, it can be divided into mechanical and neurophysiological factors. The mechanical factors are that there is decreased laryngeal elevation due to suturing of the trachea to the skin. Then there is stasis of secretion in the upper airway and cervical esophagus due to local compressive forces exerted by the inflated cuff, and these secretions, they trickle down and they cause silent or micro aspirations. The neurophysiologic factors are that there is blunting of the protective cuff reflex and loss of coordination of laryngeal closure. So whenever we are doing decannulation in post-surgical patients, supraglottic airway assessment should definitely be done, apart from the routine bedside test that we usually do. Coming to dysphagia post chemotherapy and radiotherapy. So this picture briefly describes the direct and indirect mechanism of tissue damage by radiation. Chemotherapy, it sensitizes the tumor to the effects of radiotherapy, and an addition of chemotherapy usually also increases swallowing toxicity. So the incidence of acute dysphagia post chemo radiation is 5 to 63%, and chronic dysphagia is 3 to 21%. So toxicity post radiation depends on the accumulated dose that is given, the dose per fraction, the volume of tissue irradiated, the technique of treatment, the size and extent of primary tumor. Definitely this is very important. So hypopharyngeal cancers, they have highest risk of chronic dysphagia and stricture formation, followed by oropharyngeal, followed by laryngeal cancers. Acute toxicity, apart from just generalized hyperemia, erythema, ulceration and edema of tissues, there is in the oral cavity, there is mucositis, there is voice change, there is xerostomia, soft tissue necrosis, and ORN mandible definitely it occurs. There is this also impacts the orodental hygiene. Now the late effects, there is fibrosis and atrophy of muscles, there is loss of sensation and taste, there is decreased contractility of muscles and stricture formation. Changes in speech, so there is an entity known as radiation induced dysphonia. Voice changes occur which results from edema and dryness. Then so there is harsh, rough quality of voice, there is disturbed frequency of voice, and there is vocal fatigue. So patients are not able to speak for long periods because they may also not be able to raise the pitch of their voice. So in terms of swallowing, again, because there is fibrosis and a lot of stricture formation, so there is reduced retraction of the base of tongue, incomplete closure of the epiglottis and larynx, there is decreased peristalsis as muscles are affected, there is delay in pharyngeal transit, poor coordination of swallowing muscles, there is poor synchronization of muscles, and delayed opening of the upper esophageal sphincter. So many studies have been done where conventional radiation has been given, and on the other hand, intensity modulated radiation has been given, and especially for head and neck, certain structures have been demonstrated which post-surgery, which post radiation, pathological changes are noted in these structures, and they contribute maximum to dysphagia post radiation, and these structures are known as organs at risk or dysphagia aspiration related structures. These include the superior constrictor, the middle constrictor, the inferior constrictor, the cricopharyngeal muscle, the esophageal inlet muscles, cervical esophagus, the base of tongue, supraglottic larynx, and the glottic larynx. So what can we do to minimize dysphagia post radiation? One is the use of CT for target volume delineation. Also, we have to spare the organs at risk and the dysphagia associated structures. To do that, we are now usually using IMRT, which not only spares the organs at risk but also spares the salivary glands, which leads to lesser incidence of xerostomia. Now, the recent thing that has come up is that we are giving dysphagia optimized IMRT, which is basically aimed at sparing the swallowing structures or giving minimal radiation to these structures. So there is the DAS trial, which says that it was a phase 3 randomized multi-center trial where on one hand dysphagia optimized IMRT was given versus standard IMRT, and it was seen that dysphagia optimized IMRT is better, and the post radiation dysphagia in such cases was much less as compared to the conventional IMRT. Now coming to the rehabilitation part, so voice, speech and swallow rehabilitation. So first is voice. So vocal functioning assessment, it can be done by certain scales, which are the ones which are most commonly used are the voice related quality of life questionnaire, the voice symptom scale, the voice handicap index, then the perceptual voice evaluation, GRBAS is most commonly used. So then there is grade rough breathiness, asthenia and strained scale or the CAPE-B. Then there is dysphonia severity index. Instrumental evaluation of voice is done by video stroboscopy. A diagnostic microlaryngoscopy may be required if a pathology is if a polyp or a nodule is noted on the vocal cords, then a diagnostic microlaryngoscopy may also be done. Now coming to rehabilitation of voice post laryngectomy. So there are three modalities of rehabilitation of voice. One is esophageal speech, second is electrolarynx or the artificial larynx, and third is the surgical voice restoration. Esophageal speech, it requires air to be taken into the top of the esophagus either by injection or inhalation, and it is then forced out, causing the newly reconstructed pharynx, the pharyngoesophageal segment or the vibratory segment to vibrate in response to the flow of air and produce sound. As in case of a normal laryngeal voice production, the sound is amplified by resonating cavities above and modified into speech by articulators, which are the tongue, teeth, lips and soft palate. The electrolarynx, it produces a sound that is transmitted into the resonating cavities either by direct pressure of the machine against the skin or of the upper neck or through a tube directly into the oral cavity. TEP or surgical voice restoration, it is basically creation of puncture at the time of the surgery or may be created at a second sitting, primary TEP or secondary TEP. Now TEP is a fistula which is made through the posterior tracheal wall into the esophagus. It is a one-way valve, and so once we insert a prosthesis, it is a one-way valve where only air can pass into the esophagus for voice production, but food and fluid are not aspirated. So the most common cause of TEP failure post surgery is that we have a hypo or a hypertonic pharyngoesophageal segment or the neopharynx. So in case of a hypotonic neopharynx, the swallow is functional, but the voice is of low quality. It is low, it is weak, it is whispery, it is wet. How do we manage it? We put digital pressure against the outside of the neck, artificially increasing the tone, and or a low opening pressure prosthesis may also be used. In case of a hypertonic neopharynx, increased pressure is required for swallowing. The voice is high pitched, it is effortful, and it is difficult to maintain. And How do we manage this? So during the time of surgery, we do a cricopharyngeal myotomy. Post-surgery, or we can do a pharyngeal plexus neurectomy, and post-surgery, if such a problem arises where there is TEP failure because of hypertonicity, we can do botulinum toxin injections. Coming to speech, so speech is impacted by voice quality, resonance, and articulation. Assessment is done by understandability of the speech scale and the speech handicap index. So, speech and voice therapy for non-laryngeal cancers post chemoradiotherapy. It is aimed at three. One is maintaining vocal hygiene, giving adequate dietary advice, speech therapy by a specialist, and medical treatment. So, vocal hygiene is aimed at laryngeal hydration, gentle vocalization, minimizing vocal trauma or abuse or maladaptive hyperfunction which occurs during the course of radiation. Voice therapy is aimed to overcome this maladaptive hyperfunction. How do we do that? We give certain vocal exercises with the aim of targeting and strengthening specific muscle groups and improving glottal closure and efficiency. We increase the awareness of and reduce excessive tension in the muscles around the larynx, neck, and shoulders. Then posture. Change in posture and improving breathing also impacts speech and can be improved upon. Then there is laryngeal massage and psychological counseling which is given to the patient. Medical management is basically we treat the underlying acid reflux, treatment of any URTI, LRTI or any allergies. We have to treat radiation-induced hyposalivation. So we use cialobergs or oral mucosal lubricant or salivary substitutes. Intraoral electrostimulation of salivary glands may also be done. Then mucositis needs to be taken care of. So good oral hygiene maintenance and regular gargles is helpful. Also pain management because the ulcers post radiation are very painful. Now coming to swallow. So clinical assessment of swallowing, history taking is very important. So signs and symptoms, coughing during or after eating and drinking is characteristic that the patient might be aspirating. Then there might be hoarseness, choking. Then so a complete head and neck examination is warranted. Certain questionnaire-based assessment methods for dysphagia are there. Most commonly used is the MD Anderson Dysphagia Inventory. Others are SWAL QOL, SWAL Care, then Sydney Swallow Questionnaire, University of Washington Quality of Life. Then there are certain observer-related questionnaires, which is the performance status for head and neck. Now, certain perceptual test, which is the blue dye test or the water swallow test. So the blue dye test is usually done in tracheostomized patients to see whether a patient is aspirating or not. So we give dye mixed with water. We give it to a patient who is tracheostomized, and post swallowing this dye, this colored water, if the patient coughs or if there is spillage from the tracheostomy or on suctioning, if we find the dye from the tracheostomy, then that means that there is aspiration. So we have to check both the immediate and the delayed phase for aspiration. Next is the water swallow test. We give a defined volume of water, 100 ml, and look for any abnormal voluntary cough, post-swallow cough, throat clear, or we check the voice after the water swallow test. Next are the instrumental-based measures. So there is fiber optic endoscopic evaluation of swallowing. Then there is flexible endoscopic evaluation swallowing and sensory testing. There is modified barium swallow. So FEAS is an endoscopic examination of the upper aerodigestive tract. It is useful in identifying aspirations and silent aspirations also. The advantage is it can be easily done. It's a bedside test, and the only disadvantage is that the oral phase of swallowing cannot be assessed with this. So another advantage is that endolaryngal sensation can also be checked at the same time. So what is it that we see when we do laryngoscopic examination. We go as per the penetration aspiration scale, where penetration is that the bolus material, it comes in contact with the true vocal cords without entering the larynx, and the frank aspiration is that the materials enter the lower airways. This may or may not be cuffed out depending on the grading. Now, radiological investigations include a contrast swallow and a video fluoroscopy. The contrast swallow, the barium swallow, it includes both static and dynamic assessment. Patient is given a cup of liquid barium to swallow, and bolus is followed fluoroscopically to the stomach. The video fluoroscopy is actually the gold standard for evaluating the swallowing mechanism. All three phases of swallowing can be assessed, and also maneuvers can be given to the patient, and the effect of the maneuver can be assessed using video fluoroscopy. Now, coming to management, so there is prehabilitation, then there is management immediate post surgery, and management post radiation and chemo, and then long term management of dysphagia. So there is this concept of prehabilitation, where rehabilitation starts prior to surgery or radiation, that is before commencing the definitive treatment. We rehabilitate the patient. So what all do we do? There is a baseline assessment of speech and swallowing, then there is a dental examination. The prophylactic swallow exercises, they can be offered to the patient, and this also improves compliance in the post-operative or post-treatment period. Then adherence promoting interventions like behavioral change technique, home-based mobile applications, and virtual coaching can be done. And baseline nutritional assessment needs to be done for these patients. Based on whether how a patient is doing, whether he or she has a safe swallow or not. Again, rehabilitation needs to be planned. So before starting treatment, a PEG tube or RT insertion may be considered in some cases, not all. So immediately post surgery, there is placement. During the intraoperatively, we place the Ryle's tube to commence early feeding. Swallowing exercises are usually started on post-op day 4, and a swallowing assessment by an expert is done on post-op day 5. For tongue resections, it is usually post-op day 5 and 6 that is considered as we give adequate time for healing. Once the assessment is cleared, so this assessment can be done by the blue dye test. Once there is no aspiration, then patients are started on oral sips of water. Once the patient has taken adequately, that is 1 liter oral intake is there, then we can proceed for removal of the RT. We can change the consistency of the feed by giving full liquid or blended diet for the patient. Once the patient is taking normally, then soft diet can be given, and gradually the patient progresses to normal diet. Once we have removed the RT, there is no aspiration, patient is taking liquid or blended diet comfortably, process of decannulation may also be started. Now, long-term dysphagia management, it comprises of compensation, rehabilitation, and adjunct modalities. So, management is defect-based. It requires a combination of compensatory and rehabilitative strategies. Compensatory strategies, they are short-term, temporary measures. They do not aim to change the swallowing mechanism. They usually include involvement of the the exercises are done without the involvement of the food. This is basically in patients who do not have a safe swallow. Now coming to oral stage disorder rehabilitation, first is the lip. So the labial range of motion exercises, we ask the patient to tightly stretch and purse the lips in contrasting E and U position. We ask the patient to press the lips together, open the mouth as wide as possible and hold for 5 seconds and smile as wide as possible. Multiple cycles of these exercises need to be done and not just one. So this improves labial closure and strength. Now, lip strengthening exercises are the resistance exercises. So this improves lip strength and range of motion. So we hold a tongue depressor between the lips, and the clinician tugs to remove it or apply some pressure to remove the tongue depressor, and we check how much strength the muscles have on the lips. Then straw drinking and button and thread exercise, where a button is placed inside the oral cavity and the patient himself or herself can pull it, or this can be done by a clinician. Now coming to buccal mucosa, so tilting the head to the stronger side, head tilt to the stronger side is done so that gravity drains the bolus along the strong side and avoids the weaker side. This usually protects the airway, but it may be slightly difficult for patients with tracheostomy to perform this. For tongue, so we have range of motion exercises which improve the tongue flexibility, strengthen the tongue muscles and improve the range of motion. These include the tongue tip elevation, the tongue base retraction, the tongue propulsion or retraction, lateralization movements to left and right of the mouth. So if there is a reduced vertical tongue movement, so tongue range of motion exercises are considered maxillary reshaping prosthesis, head back posture and head tilt to the stronger side. If there is a reduced anterior to posterior tongue movements, then head back postures, multiple swallows, we alternate liquids and solids. Then tongue range of motion exercises, bolus manipulation exercises, and again prosthesis may be used. And if there is a reduced tongue strength, then effortful swallow and tongue strengthening exercises. So reduction in the tongue elevation, we ask the patient to tilt the head back up. So this is also known as the chin up posture, where by keeping the head back, we use gravity to clear the bolus from the oral cavity in those who have a problem with oral transit. This cannot be used in patients who have poor lingual control or have impaired airway closure, and this might be difficult for patients with tracheostomy. Now, tongue range of motion exercises, they improve the tongue flexibility, strength and range of motion. So there is tongue tip elevation, tongue base retraction, tongue protrusion, retraction and lateralization movements to the left and the right of the mouth. Then tongue strengthening exercises, so we provide some kind of resistance. This can be done with the help of a tongue depressor or a spoon, and we ask the patient to push the tongue against the resistance. We can also use an IOPI, which is a pressure transducer. This gives a visual feedback on how much tongue pressure is generated. Now coming to jaw range of motion exercises for reduced mouth opening or Christmas rehabilitation. So unassisted jaw opening and closing is, the patient is asked to do unassisted jaw opening and closing. Then mechanically we can assist jaw opening with stacked tongue depressors or ice cream sticks, which is most commonly done in OPD. Then we may also use Therabite for Christmas rehabilitation. Now, pharyngeal phase, if there is a delayed pharyngeal swallow, then we ask the patient to perform a chin down or a chin tuck chin tuck maneuver, where airway is protected and the entrance of the airway is basically narrowed and the vallecula is widened. Other exercises, supraglottic swallow and thermal or tactile stimulation may be done. Now, in case of reduced tongue-based retraction, chin down posture, effortful swallow, supraglottic swallow, Masako maneuver, These may be done, and certain range of motion exercises like retraction of the tongue as far as possible, yawn, gargle, effortful swallow may be done. So how do we perform an effortful swallow? This is basically to improve the posterior movement of the tongue base and to increase oropharyngeal pressure. So
swallowing exercise.
So we start with the tongue at rest. We press the tongue against the roof and we swallow as hard as we can. We first keep the water in the mouth and we swallow as hard as we can. So this increases the posterior tongue base movement. Now next is the supraglottic swallow. So the purpose is to reduce closure of the laryngeal vestibule or airway entrance. How do we perform?
Robotic swallow. I'm going to use some water today. I'm going to take a sip and hold it in my mouth. And breath in through my nose, hold my breath, but swallow while holding my breath. Remember to cough right after. Again, from the side, you can swallow in.
So the rationale is that effortful breathing, breath holding tilts the arytenoids forward, closing the airway entrance before and during the swallow, and this helps to prevent aspiration. Next is the Mendelssohn maneuver. The purpose is to improve the range of the laryngeal movement. It improves the opening time of the cricopharyngeus. Laryngeal movement upward and forward opens the upper esophageal sphincter and prolongs the elevation of the hyoid or the larynx movement and sphincter opening time. Coming to the Masako maneuver or the tongue hold maneuver. So we protrude the tongue maximally, then we hold it in between the central incisors and this increases the anterior bulging of the posterior pharyngeal wall and increases the pressure, and we try to swallow the saliva in the mouth, and post swallow we just relax and we have to repeat this 3 to 4 times. Now coming to the larynx, so if there is reduced laryngeal vestibular closure, so we have the chin down posture, the supraglottic swallow, effortful swallow. Reduced laryngeal elevation, we have the Mendelssohn, the chin down. Laryngeal range of motion exercises, the shaker exercise. If there is reduced glottic closure, then we have the head rotation to the weaker side, supraglottic, and we may use thickened liquids. So this is describing the shaker exercises for hyolaryngeal range of motion. So to increase the hyoid motion, what we first ask the patient to lie down flat, and then we ask the patient to keep the shoulders flat against the bed and lift up the head and bring the chin down close to the chest. We ask the patient to keep the head lifted for 60 seconds and then lower the head and rest for 60 seconds. The second part is that we ask the patient to again keep the shoulders flat against the bed, lift the head, bring the chin down to your chest and immediately lower the head. So this sequence needs to be repeated at least 5-6 times. Now compared to coming to impaired cricopharyngeal opening, so shaker exercise and effortful swallow is useful. Adjunct strategies for dysphagia management include dietary modification and sensory enhancement. So texture modification or bolus volume modification may be done. Then for sensory enhancement, thermal tactile stimulation may be done, or change in method of presentation, as in a spoon, straw, cup may be used, whichever is suitable for the patient. Carbonation of liquids may be used, and taste modification. Use of sour boluses is helpful. Coming to prosthetic rehabilitation, this is important where we have palatal defects, and so a palatal drop or lowering prosthesis may be used. Newer modalities include EMG biofeedback and neuromuscular electrical stimulation. So with that, I come to the end of the presentation.
Excellent. Sangini ji, you have done it very well and covered almost all things. And I think everyone should understand that we should, as a surgeon, do pre-operative counseling and tell the patients beforehand what are likely consequences of the surgery or radiation or whatever treatment you are planning. And I hope that all the hospitals, they have speech swallowing therapist. Most of the good cancer centers do have. And the third aspect which I wanted to highlight was what is the role of surgery in rehabilitation, speech swallowing rehabilitation. That is also an important part of speech swallowing therapy in the form of surgery.
Yes, sir.
And any questions? Chat box is empty. Okay. So lastly, I will just say 27th July happens to be World Head and Neck Cancer Day. So all of you must celebrate it and try to create awareness in whatever way about head and neck cancers.
Yes, sir.
You are doing it in your hospital?
Yes, sir.
Good. Anji, Mr. Yuvraj ji? Mr. Yuvraj?
Yes, sir.
Can we call it a day? She has done it very well. She has completed. There is a question, what are the problems you expect with the TEP and how do you troubleshoot them? Sangini?
Sir, again, I've already mentioned that there might be hypotonicity and hypertonicity. So a hypertonic pharyngoesophageal segment is the most common cause for a TP failure, and intraoperatively we might do a cricopharyngeal myotomy or a neurectomy, and in post-op we can do botulinum toxin injection.
Good. I think we have covered it once. Maybe we can take up these issues, post-laryngectomy complications, how to deal with them. So Yuvaraji, we call it a day. Thank you all.
Okay, sir. Thank you, trainees and